I'm Sarah Green, and I'm the Executive Officer of the Health Services Research Association of Australia and New Zealand. And our webinars feature the best HSR in Australia, New Zealand and internationally. And currently we're focusing on the winners of our 2018 HSR Awards, and our presenter this morning was a winner of our Best PhD Paper Award in 2018. Our webinars are open to members and non-members, but we do encourage you, if you're not a member, to just take a look at our website and our other activities and benefits and our membership options. And just on the screen here, our key activity this year is our Health Services and Policy Research Conference being held in Auckland on the 4th to the 6th of December. And we have literally just opened the call for organised symposiums, and that call closes on the 5th of April. So if you take a look at our website, you'll find all the information on our website. Housekeeping issues. You should be able to see the slides and the talking head videos at the side of the screen, but we can't see or hear you. But you can communicate with us using the chat button, and you can ask any questions you've got for Tim using the Q&A button at the bottom of the screen. And what will happen, Tim will talk for about, I think, 30 to 40 minutes, and then we'll take all the questions at the end of the session. And we are recording the session, and I'll have the recording up on the HSRAANZ website in hopefully by tomorrow morning. I'm going to hand over to Tilly Payne now. Tilly is Principal Research Fellow for Allied Health Professionals at Townsville Hospital, and she's a member of the HSR Executive Committee, and she'll chair this morning's session, and she'll handle the Q&A session at the end. Thanks, Tilly.
Thanks, Sarah. Thanks, everybody, and welcome. It's good to see such a great turnout. As Sarah said, my name's Tilly Payne. I'm pleased to have Tim here. His paper from last year was excellent. We had some great submissions, so I'm looking forward to hearing the presentation. I will do my best to monitor all of the questions as they come in and try and present the best ones to Tim. But if you have something that's burning, please put it in capitals or something so that it stands out for me. And I'll pass them on to Tim as he finishes his presentation. So thanks, Tim, and I look forward to this presentation.
I'll just quickly introduce our presenter today. Tim Badgery-Parker is a research fellow at the University of Sydney within the Faculty of Medicine and Health, School of Public Health, Menzies Centre for Health Policy, Charles Perkins Centre, and Tim recently submitted his PhD in the Menzies Centre for Health. His research focuses on measuring low-value care, defined by choosing wisely, RACP Evolve, or similar recommendations in the New South Wales public health system.
Okay, thank you, Sarah and Tilly. So this work I'm presenting today is basically a part of my PhD, which I recently submitted. So I was looking at measuring low-value care in New South Wales public hospitals. So there was a team, it's not just a single group. I was funded by Capital Markets CRC in partnership with the University and New South Wales Health. There was another PhD student, Kelsey Chalmers, that did similar work. I was working in public hospitals, she was using private health insurance data. And of course, supervisors, clinical advisors. Jonathan Brett was also doing a PhD of his own in low-value prescribing practices. And then there's managers at New South Wales Health that I was directly working with. So I'd just like to thank all of those people. So low-value care, a lot of people know about the Australian Atlas of Healthcare Variation. So the atlases, they show how much the rates of use of procedures in different regions. And by their nature, they direct focus to the extremes, the areas with high and low users. So these areas are high and low. And there's a tendency to assume that if the rates are high, then there may be some overuse or low-value care occurring. And conversely, if in an area with low rates, then there may be people missing out on care. But they're an indirect measure of low-value care. We don't actually know how much low-value care is occurring anywhere. And because they're focusing attention on the extremes, we're missing out on all these people in the middle who may also be subject to low-value care. So the aim in my project was to develop direct measures of low-value care, to directly identify low-value care at the individual patient level. And my model for this was a paper published by Erin Schwartz from Harvard. My supervisor, Adam Elsworth, was also co-author on that paper. And so the starting point was, can we replicate that work in the Australian setting? And the advantages of developing direct measures is, unlike the Atlas, which just looks at where rates are high and low, we can actually look at the rates of low-value care specifically. And then, because it's actually, we're measuring at an individual level, you can aggregate to any relevant levels. So you can look at low-value care in hospitals or local health districts or across the state. And you can also look at associations between the low-value care and other factors, and I'll go into that later. So to start with, I probably should define low-value care. Simply, it's care for which the expected benefit does not outweigh the potential harms. In practice, for this study, I'm using a guideline-based definition. Essentially, if there's an evidence-based clinical expert group has recommended not to use a procedure in a particular patient group, then I'm measuring, is that procedure being used in that particular patient group? And if so, that's low-value care for my purposes. And you can see there the various sources, the recommendations that I've been working with. So the first stage was to develop the indicators, and this was published, basic methods were published early last year jointly with Kelsey, who, as I said, was doing similar work in private health insurance. And there's a lot of recommendations out there, even just in the limited sources that we looked at. And so our first thing was, what can we actually measure out of those recommendations? And we came up with these 4 criteria for selecting the recommendations that we were going to look at. And the first point is, the recommendation has to relate to care that occurs in the setting. So I'm looking at inpatient care. So any recommendation involving care that's sort of general practice, or some recommendations specifically limit their scope to emergency department, they're just completely out. I can throw them out. Then it's got to be care that can be recorded in the data that I'm looking at. So I've got inpatient claims data. I don't have information on prescribing and pathology testing. There's a lot of that occurs in the hospital. It is recorded, but it's not in the data that I've got access to. So again, I can't measure those recommendations. Then the third point is, can I reasonably identify the patient group for which the care is low value? And this is where I have to make judgment calls. Clinical advisors came in, and we came up with, well, can we actually measure this particular recommendations? And the first point we had to put in, because of the Australian coding rules, there's a lot of procedures which are not normally coded according to the rules. And that was especially relevant for imaging. So a lot of imaging occurs in hospitals. It can be recorded in the data, but the coding rules say it's not normally coded. It's not normally recorded. So we wouldn't know how much we're actually picking up if we tried to measure those recommendations related to imaging. And I suspect that the ones that do get coded are the more serious cases where the imaging was appropriate anyway. So that was our criteria for working through the recommendations and finding out what we could measure. Then we had to turn those recommendations into the measurable indicators. And this is how I conceptualize it, and it's basically how my code works. First of all, I pull out the red group of patients who receive the service that we're looking at. Then I pull out all the patients in the group where the recommendation is that they should not be receiving it. I also look at patients who have an indication which would justify the procedure. And then the low value care is anyone who should not be receiving it according to recommendation and doesn't have any other indication that would justify it, and they're low value care. And for the later results, where I'm looking at prevalence and rates, my denominator is this red group of patients who receive the service. So I'm looking at, of all the care that's provided in these particular procedures, how much of that is low value. An alternative is to look at a patient denominator of how many of the patients who should not be receiving it, how many are receiving it. But for this, I'm just keeping on the service denominator. So one of the points we took from Schwartz's paper and applied here was providing 2 definitions of low value care, a narrower definition and a broader definition. And this is because basically the procedures we're looking at, they're not low value in every case. They're low value in a particular. There are some patients who clearly benefit, some patients who should not be receiving it, and there's a curve there, and you've got to set a threshold somewhere as to where do you cut off and say, well, no, the patient should not be receiving it. And that threshold is set by the recommendations we're looking at. But there may be cases where there are multiple recommendations for one service, and one may set the threshold here and another may set it up here. There's also some uncertainty in how we actually can operationalise those recommendations because of limits of the codes or the data that we have available. So our aim was to develop first a narrower definition which, as far as we could, only captures red zone, the care that was clearly low value. And then where possible, we expanded that to try to capture more of this grey zone. In an ideal world, we'd exclude all the green ones, capture all the grey ones in the broader definition and all the red ones in the narrow definition. In practice, we don't actually know where our definitions fall along that curve, but that's our aim. And the idea is that if we take the narrower definition, we're reasonably certain that we're not capturing any of this green group. So I'm just going to work through an example of how we took the recommendations and turned them into our indications. Here are 3 recommendations from different Choosing Wisely initiatives relating to carotid endarterectomy for asymptomatic stenosis. Now, if you look at the bottom one, this is from America, and it specifies the complication rate is low. Now, we cannot measure the complication rate. We don't have any data to estimate it. So on our criteria for what recommendations can be measured, we just have to throw that out and say it's not a measurable recommendation for us. So then we've got these 2 left. The top one from Australia is fairly broad. It's just do not routinely recommend surgery for stenosis that has not caused symptoms. And then the Canadian one is a narrower one. They specify in high-risk patients with limited life expectancy. So in developing our indicators, if we go back, we're basically, our narrower definition is going to be based on the Canadian definition, which specifies the particular patient group, and then we'll expand that to a broader one to say, well, anyone not where the stenosis has not caused symptoms. In practice, what we came up with is these 2 definitions. Don't expect to go through read through it all, but to highlight the points in the recommendations, they all refer to asymptomatic patients. So what we've done there is we've looked at diagnoses of stroke or neurological symptoms. So basically, our data records diagnoses. It does not record symptoms, except in very rare cases. And of course, it doesn't record a lack of symptoms. So we're presuming that if someone's got a diagnosis of stroke or neurological symptoms, then they probably had symptoms when they came into the hospital, and therefore the endarterectomy could be justified. Stroke is in fact a complication of carotid endarterectomy. So someone could have come in asymptomatic, had the endarterectomy and suffered the stroke. We can't detect that. So we're trying to be conservative and saying, well, if there's any sign that they had a stroke, we're going to say the procedure was justified. I've also put in there, for the narrower definition, emergency admissions as not being counted as low value, because we're presuming that if someone's coming in as an emergency, they're more likely to be symptomatic. The next one we looked at was high-risk patient, and for that we've used the American Society of Anesthesiologists code, where that goes from 1 to 5 of the patient's risk. And we've said if someone's in code 4 or 5, that's the high-risk end of the scale, then we're going to call them a high-risk patient and say they should probably not be having the endarterectomy. And finally, the limited life expectancy, we picked a cutoff of 75. That's actually mentioned in the notes to both the Australian and the Canadian recommendations. As the evidence is above 75, there's less benefit from the endarterectomy. But our clinical advisors said, well, you know, you can actually do it in older people. Had one person say, you know, I'd be quite happy doing it in a fit 85-year-old. So for the narrow definition, we've also included this ASA3. So anyone who's got an ASA score of 1 or 2, doesn't matter how old they are, we're going to say that you can probably justify the endarterectomy. So that's just working through one example of how we went from recommendations to our indicators. Said we did that in 27 cases. So I'm now going to go on to the main results paper that was published last year. This is the one that got the Health Services Association Award for Best PhD paper. It's basically an overview of all the 27 indicators across the New South Wales as a whole. So this figure summarises the study. As you can see, we screened almost 2,000 recommendations. Just under a third of those were actually relevant to the inpatient hospital setting, and we ended up with just 27 that we could actually develop an indicator and measure. And then from those, when we look further, we said half of those, 13 of them, would count as negligible. We're not going to worry too much about them. 7 of them, trends decreasing, so that's good. And then 3 we found had an increasing trend, and we said, well, they're a priority for further investigation. And that's really the aim of these indicators. What we can use them for is investigating where you might want to look further to intervene, to find out what's going on, or try to reduce the low value care. We can't tackle everything at once, so where can we actually go and have the best chance of providing a benefit? So this just summarises the 13 that we said are negligible. I don't expect you to read through all that. The main point to take is that the total volume of these is generally low. They're quite small numbers in total, so they're just not being done much in the hospital system. And then numbers that we're identifying as low value are much lower still. And this is where we've said they're negligible. And I forgot to mention back earlier with the carotidectomy, they referred to do not do routinely and do not do in most patients. I forgot to mention that's one thing we can't actually directly put into our indicators, but here we're sort of taking that into account. If something says don't do it routinely and it's only being done 4 times across the state in a year, then I think we say it's not being done routinely, and these particular cases may actually be the exceptions that are justified. That's especially relevant for vertebroplasty, where even though it's been removed from Medicare benefits schedule here, there is actually a recommendation from NICE that says it is appropriate in certain highly selected patients. Now we've got 15 that we said were low value. Well, that's probably certain highly selected patients. So basically we're saying we're not worried about these ones. It seems that the evidence is being incorporated in practice. Then we have these other 14 with higher volume of low value care. And again, you see the total volumes are also much higher. These are procedures that are actually being used in the hospitals, and a certain proportion of them are low value. And that's ranging from 2,000 up here for endoscopy for dyspepsia in adults under 55, and down to about 23 for epidural steroid injections. So there's a wide range of what's counted as low value. Our threshold for cutting off between the 13 negligible and the 14 worth in further investigation was basically a simple median split. But again, the point is that these are procedures that are worth investigating further. We want to know what's happening. Should we be intervening to prevent these, or are these 23 cases actually okay? I'm actually open, even though I've developed all these indicators, I'm open for someone to come back and say, well, yes, we've investigated those ones that you say are low value, and they're actually okay for these reasons. And from my point of view, that's a good outcome. The point is, where should we target our investigations? And that's what the indicators can be used for. So this presents counts per year for the 14 high volume indicators. I should point out that the vertical scales vary. We've got, that's just over 100 here to up to 15,000 here. So you're not meant to compare between panels here. The idea is just to look at the trends within each panel. And the main point I want to show you is that the low value care is actually a very low proportion for most of these. Renal artery angioplasty is one where almost all the care is contrary to recommendations. The recommendation is basically don't do it except for very specific cases. But other ones, colonoscopy, as you know, colonoscopy is very high value in detecting cancers, investigating bleeding and such. So we're finding very few are actually coming in as low value. The other thing, some of the total volume has been decreasing, as not just the low value volume. So we don't know exactly what's happening there. Again, the idea is this is highlighting patterns that we should investigate. It's possible that there are what we've identified as low value is not the full low value, and that there is just a general movement to reduce low value care in the procedure. It could be that I'm only looking at public hospitals. It could be that these procedures are moving into private hospitals. Again, the idea is we can identify patterns and then we need to investigate further to find out what they mean. So this is just another look at the trends in the low value care in the numbers of counts, but just highlighted by the initial thing of decreasing, no trend, or increasing. So these left panel where it's decreasing, there's some high volume low value procedures here like arthroscopy and abdominal hysterectomy versus vaginal laparoscopic approach, but they're trending down. So from our point of view, and this is the point of view of my people I've been working with in health, there's not a problem there. The evidence is that these are low value. Our results suggest that the clinicians are taking that evidence into account and practice is changing. But over the other side, there's these three which have an increasing rate. And we say, well, we want to know why. If the recommendation is not to do these procedures in particular patient population, why is the number of procedures in that patient population increasing? So they're listed in red on our summary slide saying these are a priority. We want to know why these are increasing. The other thing we can look at is the difference between hospitals. And you see there's a lot of variation between hospitals in the prevalence of low value care. So I'll just explain this slide. There's red bars here. That's the overall state rate of the low value care. So of all the services, like all the endovascular aneurysm repairs in New South Wales, just under 50% were listed as low value care, as in being in an asymptomatic high risk patient with limited life expectancy. And each dot represents an individual hospital that performs the procedure. The orange dots, they've got significantly higher rate than the state average. Blue dots, the hospital has a significantly lower rate than the state average. So again, this can focus our attention on where should we be investigating and possibly intervening. We need to know why these hospitals have high rates. We can't tackle all of low value care all at once. These indicators say, well, if you're going to tackle it, go on and look at this hospital that's doing 80% abdominal hysterectomies, when the recommendation is you should prefer a vaginal laparoscopic approach. The other message you can take from this, if there's hospitals that have lower rates, these blue ones, what are they doing right? And have they got lessons that can be applied across the whole system? So it's both find out why some hospitals have high rates, what can we do about it, but also why do they have low rates and does that help us in reducing low value care across the system? So this graph just shows the narrower definitions. I've been focusing on the narrower results right through. Here is just to show what happens when you use the broader definitions. You can see from narrower to broader, everything jumps to the right. We're identifying a lot more as low value. The total variation also increases. There's a lot wider range in most of these between the lowest and the highest. But again, the same message that there's hospitals that have higher than average rates, and there's also some hospitals that have lower than average rates. Another thing we can look at is the trends between hospitals. As I said at the beginning, one advantage of the direct measures is that we can aggregate at different levels. So this is New South Wales, the average rate. I'm only going to use the one example here in knee arthroscopy. And you can see it's been declining over the 7 years of the study. It's basically halved from 0.2 to 0.1. So 20% were 20% of arthroscopies were low value by my definition in 2010, and that's come down to about 10% in 2016. If we look instead at the LHDs, there's a bit of variation. Some LHDs have higher rates, some have lower, but they're all showing the same pattern. They're all declining. There is clearly an understanding that we should not be doing these knee arthroscopies and people are reducing the use of it. Then we can look at the hospital level. The first thing to notice is there's a lot more variation. Some hospitals have quite high rates, getting up above 50%. But you can see there's a general pattern, but the curves are following the same pattern as the state and LHD levels. But there's a few hospitals that are going the other way. So 3 of the 4 hospitals that had the highest rate in 2016-17 have actually increased since 2010. So again, that's where would you target your investigations? What's happening at those hospitals? If the majority of hospitals are reducing use of knee arthroscopy, why are those 3 increasing it? And if you look further, there's actually a few more that have also been increasing while everyone else is decreasing. So again, this indicator shows where we can target further investigations to find out what's happening, who's doing the low value care and what can we do to reduce it. Something else I was going to say about that. Oh yes, that's right. I should point out that those 7 hospitals that are highlighted there, they're in different LHDs. As I said in the previous graph, all the LHDs are showing a similar trend of all decreasing. So these hospitals are across those different LHDs. Every LHD, well, not every, because there's only 7 of them, but LHDs have problem hospitals even when overall they're doing the right thing. And when I say problem hospitals, of course, we don't actually know what's driving this, and there may be a justification for it. So I'll just mention a bit about some of the limitations of these indicators. The first point, and the one that is always the first thing people raise with me, is you don't have all the information that the treating doctor had. So how do you know that you're actually correctly identifying this as low value? There could be something that you don't know that the doctor knew, which justifies it. And you just have to admit that's true. But we're doing the best we can, and one of the things I highlight is we only had 27 indicators out of 625 that we set, recommendations that we said were relevant to the hospital setting. We ended up with 27 indicators, because if we weren't reasonably sure that we could actually identify the group that's which is low value, we did not make an indicator. So ideally, we would take our indicators and do some chart review to compare them to see just how accurate they are. We haven't yet been able to do that. I'm still looking into whether and how we could do that. Some other studies of similar indicators relating to inpatient care have done chart review, and they've generally have found that the indicators underestimate the low value care. Once they go and look into chart review, they say, well, actually, if we classify this as appropriate, inappropriate, we're getting more inappropriate when we look at the chart than the administrative data indicator came up with. There was one study that looked at indicators in primary care, and that found that when they went and looked at the full chart record, that there was a lot more justification for these procedures, and so the indicators were overestimating. So again, we don't know if that's a real difference between primary care and inpatient care, but it can go either way. The indicators may be underestimated, they may be overestimating. I personally believe that our indicators underestimate the rate of low value care. And I have actually done some modelling. I'm not going to go into this. I'm trying to prepare that for publication, but it's not an independent validation. I'm using the same data, but my modelling does suggest that our indicator is more likely underestimating than overestimating. But in any particular case, you may be able to say, no, that particular one was justified, your indicator was wrong in that case. So just as an example of that, there was recent correspondence from Rachel Morton and John Thompson at Melanoma Institute. One of our indicators, one of the ones that we said was a priority for investigation as the rate was increasing, was about sentinel lymph node biopsy for melanoma in situ. And basically, you should not be doing it. And Rachel Morton and John Thompson came back and said, well, we don't believe anyone is doing it. And they came up and presented a plausible explanation for our results. And basically they're saying, someone's got something on their skin, they go to the general practitioner who cuts it out, sends it off to the pathology, and that comes back and says it's malignant. We don't have any of that information in our data. So the patient has actually had a malignant melanoma. Because it's come back malignant, they then go into hospital to have a wider excision to make sure they've got clear margins. And at that time, they also have the lymph node biopsy. And because the GP actually cut out all of the malignancy, the wider excision pathology in the hospital doesn't identify malignancy. So it comes back as melanoma in situ associated with a sentinel lymph node biopsy. So that's something we didn't consider that possibility. I mean, we had clinical advisors who went through everything with us, but nobody working directly in that field presented this as a possibility. We'd like to investigate that further and see if that's what's really happening. We don't know why, but it does point out that, as I said all along, we want to investigate these cases. This is one these people have investigated and said, well, this is what we think might explain the results. And I'm quite happy that, okay, we now know that sentinel lymph node biopsy is probably not a problem because there's this other explanation. but it's still worth investigating to see if we can confirm that. Another limitation of these data of the indicators is that we're only measuring against specific recommendations. So, for example, with hysterectomy, the recommendation we're working on is that you should use a vaginal or laparoscopic approach, rather than an abdominal approach. And we have not looked at whether the hysterectomy itself is justified. We're just assuming if a woman's gone in to have the hysterectomy, that's one thing, and we're not looking at whether that's appropriate. We're saying, was it vaginal laparoscopic? If not, did they have something that justifies the abdominal approach, such as a cancer or endometriosis? Another example, our recommendation that we're looking at is about colonoscopy for constipation in people under 50 with no other alarm symptoms. So we're not talking about people who've had unexplained weight loss or they've got gastrointestinal bleeding. They've just got constipation. There's nothing else to say there could be a problem, and they're younger. Family history is nothing, no family history of bowel cancer. And we're saying, well, those people, it's low value. But there's also people above 50 who are in the screening population. Supposedly, if you've had a clear colonoscopy, you should not be having another screening for 5 to 10 years. But anecdotally, we're told that people are having it after 2 or 3 years, maybe even annually. We haven't looked at any of that. So just because we've said that something is not low value does not mean it's actually not low value. But for the purpose of looking at these recommendations and working out where we can investigate further, we can say that there's a problem in this particular case related to the specific recommendation. So what should we use these indicators for? I think I've highlighted right through there for identifying where we can investigate further. What can we look further at? What procedures should we be targeting for investigation and maybe trying to reduce? What hospitals should we be investigating? Ask them why the rate's high, or why are your rates low? What can you teach us for other hospitals? For monitoring the rates and trends, and relate to that to evaluate any initiatives to reduce low value care. And coming into that is feedback of the results back to the hospitals and clinicians, so they know where they stand in terms of low value care rates. One thing I'd be very wary of is using these indicators for any sort of penalties until we've had more investigation, understand what's driving these results. And the sentinel lymph node biopsy is an example that there may be plausible explanations that we don't know about yet. So now I'll just move on to another further use of these indicators. One of the advantages of the direct indicators, as I said at the beginning, is you can then look at associations with other factors to either to explain what's happening or to look further at further aspects of care. This is a paper that was published last week where I was looking at some of the downstream consequences of some of these low value procedures. So for these 7 procedures that we looked at, the recommended care for the patient group where it's low value generally should not involve hospital admission. And yet, if they come into hospital, some of them are getting harmed. So I've used the Australian Commission on Safety and Quality in Healthcare list of hospital-acquired complications. That's 16 complications that they're using for monitoring quality and safety. And we find that patients, high-risk patients who should have an asymptomatic aneurysm, they should be treated basically watchful waiting. But if they do go to have an endovascular repair, 1 in 7 of them are suffering one of these 16 complications. So we're actually harming the patients by giving them care that is inappropriate. Similarly, I'll just go to spinal fusion, I'll highlight. There's about 7% of people who go in and have spinal fusion for low back pain are suffering one of these complications. And yet the spinal fusion, the best evidence is that it's unlikely to help their low back pain. I'll just point out here that if they're having spinal fusion for an appropriate indication, they may still have a 7% complication rate, but they're expected to get benefit from the spinal fusion. So the point here is that these are patients, they're not expected to benefit from the procedure, and yet they're getting this measurable harm. Even the safer procedures, colonoscopy, endoscopy, knee arthroscopy, very low complication rates, but there's still measurable harm for a procedure that this particular patient group should not be receiving. And this has a substantial additional burden for the patients. Just one example again, go back to knee arthroscopy. The ones who come in, have a knee arthroscopy for their osteoarthritis, which the recommendation is don't do it. They would expect to have basically one day, an overnight stay. But some of them are suffering one of these complications and spending 10 days in hospital. So it's not just, slow value care is not just a cost issue, it's also patient safety issue, patient burden issue. I'll just quickly highlight, this is the breakdown of all the 16 HACs. The main one that stands out, the third line from the bottom, is hospital-acquired infection, and that's basically what stands out as this is what your biggest risk is in hospital. Patients who, the asymptomatic, high risk, low life expectancy, no symptomatic stenosis, they go and have the endarterectomy. 10% of them are having cardiac complications as a result. But they should have been, according to recommendations, they should have been on the best medical management. The HACs that I've used, that's underestimating the harm. As I said, we're only looking at 16 complications, and they're actually chosen by the Commission because risk mitigation can reduce the risk of these complications. So these are things that really, the hospital's providing really good care. They should be very low rates of this, and yet there's still measurable harm for these patients who should not be receiving these procedures. There's a lot more complications that are possible in hospital, and again, if it's low value care, if the patient should never have been in hospital for the procedure, then every complication that happens in hospital is really preventable by not providing that low value care, not admitting to the hospital. Also highlight, we've only looked at the complications that occurred in that same episode. We haven't looked at the full cascade of later readmissions, treatments, further treatments for the complications, and then any further complications that may occur, or there's a full cascade of things that can come out of one admission for an inappropriate indication. Furthermore, there's also, we've only looked at physical harm, there's also other forms of harm for patients, such as a financial burden from out-of-pocket costs, or just time off work for treatment, and then psychological issues such as stress and anxiety over the condition or its treatment. So that's really all I've got to say. It's just a very quick summary of a few years' work, and I look forward to your questions.
Thanks very much, Tim. That was really well done. We have one question on our chat here, but I wonder if I can jump in as the host and ask a question. So I work in a health service, so this is all very interesting. And the term low value care, I mean, it sounds quite self-explanatory, but the way that you're explaining it, it's really quite complex. Is it context-based for each individual hospital or each individual procedure? And based on that, you know, do you have a sense of that cost of that low value care or the adverse events from it?
Don't have a sense of the cost of the adverse events. The paper, I did present some cost estimates. They're actually overestimating, I think, the true cost, because I just added up the cost of the entire cost of the episodes where the low value procedure occurred. And in a lot of those cases, the patient would have been in hospital anyway, even if they weren't getting low value procedures. So, but that came out between $50 and $100 million, depending on whether you're using the narrower or broader definitions, for the episodes involving the low value care. But some of that cost would have been incurred anyway. We haven't looked at any costs for these downstream consequences. That's exploring the cascade is something I wanted to look into further, and hopefully we can look into costs there, get some idea of what the true burden is. Yeah. As for the other thing about whether it's context dependent, for the procedure, it does depend on the procedure as to what's low value. But across the hospitals, the recommendations are pretty much standard. There may be issues where, you know, if a hospital is a really top specialised neurovascular centre, then maybe carotid endarterectomy in high-risk patients is more appropriate at that place than at your standard neurosurgery unit. But that's not something I can really comment on at this stage. There's a lot more further work needed.
Okay, great. Thanks for that, Tim. I just want to encourage everybody that's online to submit your questions through the Q&A button if you have any questions for Tim. We have one, it's regarding the IVC filters in the high volume list of low value care. The thought from Chaitanya was that the IVC filters volume would be low value care, I think she means.
So in here, so we found 191 episodes in total, and we counted 70 of those as low value care. This is on a narrower definition. The recommendations that we're looking at are pretty clear that you really should not be using it unless there's pre-existing embolisms or history of embolism. So that's what we're trying to get at in our definition. I can't offhand remember exactly what we included in that. So I'm not sure exactly what the question was about.
I'm assuming that there's no extra typing just at the moment, but there is an additional comment from that participant. So it's interesting to see the information on HACS in patient receiving low value care. Are there any dollar figures on the implication of HACS in low value patients? That would be good information to get the message out loud and clear to the clinicians. Low volume, yes, that's in reference to the IVC filters, I'm assuming. Yeah.
Well, as I said before, I haven't looked at costs related to the HACS at this stage. It's certainly something that we should look at in future. One reason for doing that analysis using the HACS is because IPA have actually proposed penalising hospitals if they have HACS. And so that helps. We can say, all right, first of all, the recommendation is not to do these patients, not to give these procedures to these patients, and some of these patients are getting the HACS, and IPA is then going to reduce your payment. So that's sort of try to highlight that it is actually a financial challenge to the hospitals if they're providing slow value care. But I haven't gone into any of that. That's more the ministry policy side, which I'm providing results to inform that. I'm not developing or applying their policies.
Okay, so we've got a question from Gary Disher, just to say that New South Wales Health has adopted a definition of value that includes the improvement of improved health outcomes that matter to patients, improved experience of receiving care, improved experience of providing care, or the first one from patients, the second from clinicians, and improved efficiency and effectiveness. How would we reconcile your findings against this expanded definition of value?
Well, I'd say there's two sides to value. Basically, you want to increase value, provide better value care, which is really the New South Wales Health strategic direction, is to provide better value care. One side of that is to reduce low value care. So I'm really just focusing on that side. Where is the low value care? Where should we be looking to reduce the low value care? And I'm aware there are other initiatives within the ministry, within New South Wales Health, on the other side of to provide better value care in certain procedures or in certain patient groups. But again, my work hasn't directly linked into that. It's informing, it's showing one area where you can reduce costs, reduce provision of services, and then you can redirect those resources into better value resources, better value procedures or better value care.
Just another question that's popped up. Did you investigate or uncover any non-surgical low value care medical treatments, medications or models?
Most of those, well, I think all of those came up as things we couldn't measure in the data that we were looking at. And was disappointing to me. I would really like to, I think a lot of it is going to be in the pathology testing. I'd like to get hold of some of that data to do, apply these methods to find the low value pathology testing and identify that. But that wasn't data that was available to me for this study. I was still looking into what other data sources I could get to expand this work.
Yep, okay. Just another question regarding, are you aware of any penalty anywhere for the low value care that's being conducted?
Any penalty? I'm not sure offhand what's happening in the United States. Some of their health funds have been doing this sort of work of measuring and identifying low value care. Can't offhand say what's happening there. In Australia, I'm not aware of any actual penalties applying, although I know it has been discussed. The people I was working with had been discussing some of the options of what may be possible in future. But I'm not aware that anything's actually in place. But it's certainly, there are people considering it.
Certainly, some of the complications that you listed towards the end there are some of the penalties that are carried with with ABF. So, who knows where that extension goes to.
Yeah.
Tim, I do have another. So somebody's having difficulties hearing the questions to Tim. I do apologise for that. I will see how I can increase my volume. So that's just a comment regarding the volume. That's possibly my fault. There's no additional questions at this time. Is there anybody else for more questions for Tim? Okay, then, Tim, oh, sorry, hold on, here we go. What action was taken for hacks? Just wondering if that's going to be finished. That doesn't sound like a full question yet. Yeah, what action was taken for hacks in low value care?
At this stage, I'm not sure that there's any actual action being taken. I just identified those results that have been published. I'm not actually working within the ministry now, so I'm not sure how they're going forward with this work. But from my point of view, that study was mainly proof of concept to see that you can actually use these indicators to start to investigate the cascade. But yes, I know that the people at the ministry directed me to do that. They're interested in the results, but I don't know actually what action is coming out of it.
That's excellent, yeah. Okay, so no further questions have appeared, Tim. So I just want to thank you for your time and for your presentation. I certainly enjoyed it and got a much better picture of what low value care is. It's often brandished about without full knowledge of the meaning, I think, in health services. So I want to thank you for that.